Go ahead.
Good afternoon. My name is Elsie Gayle. I am a practicing midwife in the United Kingdom. I also have extensive midwifery and nursing practice across the diaspora, having worked in countries of the South following my excellent training in nursing and midwifery in the United Kingdom. I'm on my way to Geneva because I think the issues for maternal and child health in our communities across the diaspora are critically important to our health and well-being and our sustainable, well-living lives into the future. So this is only a part of the presentation that I will be making to the forum as time goes on. This is about understanding childbirth within the diaspora, particularly in the UK, because this is where my main practice is. And I'm looking today at the personal and collective journeys to how it is that we repair our reproductive health and well-being in the diaspora, across the diaspora, based in the United Kingdom experience. So this is me and my colleague. We came together to set up a small independent practice focused on cultural safe care for Black women, for midwives and their babies and the families in the communities. We have been doing quite a lot of work. So for example, we inaugurated the all-party parliamentary group for Black maternal health in the United Kingdom, having taken a vote in Parliament Week in 2019. We've also been very successful in achieving funding to set the first Black reproductive conference in 2019. And we have been part of a whistleblowing pilot in the NHS, which actually allows people who have concerns to raise them safely within healthcare. We practice in Birmingham because Birmingham is an area where disparities are huge and there's a lot of issues for women of African descent. In the United Kingdom, then, what we have seen over a number of years is the fact that there is a huge disparity between Black women and women who are of white European descent. One of the anomalies here is the fact that if you look very closely at women who are Black and who are mixed race, if you combine those two figures, what you will see is that there is an enormous disparity. So, for example, there are people like myself who are of mixed race, but who identify as Black. And we think that these things are really important when we look at data. You know, we need to have accurate data so that we can actually understand what is going on for our communities. This is the model that we've developed over time. We've had a bit of funding here and there. We've spent a lot of volunteer time to develop the practice that we know will make a difference for women of the diaspora. The focus that we have is the Sankofa bird. So reproductive Sankofa, we call it, and basically it is so that we can go back to have a really good look at what the issues are for us using the lens of the Black woman, Black families, and Black midwives in order that we can find the way to go forward to repair our issues. What is at risk? Well, our mothers, our babies, and ultimately our communities within the diaspora. What we find then is that we have really great policies, but actually bringing the policies into practice is hugely difficult. There is a complex issue in terms of how maternity services work, and then how race and gender come together to impact on a negative scale our communities. Better Birth is one of the really good policies that we have in the United Kingdom. That is now under revision because clearly there are issues which are not have been addressed and we need to get that sorted out. One of the main issues is the fact that the authoritative voice, that is the folks who have the power to direct, to fund, to resource our service, perhaps do not have the same lens as we do. So consequently, a lot of the issues are not properly resolved, even though on paper they may look to be the right way forward. But what we're finding, certainly when we speak to midwives, when we speak to the mothers, that their journeys do not coincide in a way that actually makes a difference for our communities. So we're looking at that. Deaths are supposed to be 3.7 more times for our community than for white European women. What is worse, and what is very difficult and almost impossible to measure, is the concurrent morbidity that accompanies this. Very difficult to measure, but actually very significant for our communities, because these are the things that impact us in ways that perhaps we don't recognize until it's too late. Some of us are saying that we are being blighted on the vine. So if you think of the umbilical cord as a vine, when we look at how it is that we are impacted in pregnancy, what we have known or found, certainly looked at and researched and agreed, is that the first 1001 days of life, from the time of conception to the time that the baby is 2 years old, are critical to the holistic well-being, both emotionally, psychologically, as well as physically and mentally. That has been something that has been agreed and certainly taken to Parliament in the United Kingdom. What we then know is that there's an intergeneration imprinting through DNA, which actually affects us economically, academically, when we're looking at things like public health in preventative health care, and then the criminal justice systems. Latterly now, we're actually looking at how it is that the environment affects us. So that is the latest addition to this list. The COVID pandemic, we know right across the world, has impacted African communities badly, particularly in the UK and countries of the North. There have been quite a few difficulties. We've had quite a few more deaths. And when you're pregnant, because your immune system is lowered, it is easier for women to become COVID positive and actually have died from COVID-19. Then the traumatic effects of the lockdown, where people had no visitors, they had to attend visits by themselves, including scans, where they would normally have had partners with them, particularly when things were not going right, you know, in case of a stillbirth or something like that. They definitely needed folk around them, and there were restrictions in place as to who could accompany the women into hospitals. So there has been an increase of women who have been traumatized, and we are yet to see the results of that. We have couched our work in cultural safety, which basically means that professionally, organizationally, and personally, we are able to allow the power for decision-making, for bodily autonomy to be given to the patient, the woman, the families, so that they actually can choose a service which they feel safe to engage with. This is also based in the continuity of carer, where we develop the relationships of trust and confidence. And that actually returns birth to a more humanized way of working. So we started at the root. We're looking certainly in terms of research and development. We are based in Sankofa. And what we've realized is that our knowledge, our lens, our way of working actually encourages us to train and support our own midwives. We also need to be very focused on prevention and health promotion and care that's based in the community. That is not to say that women will not need medical attention, but primarily in terms of midwifery care, it is the midwife, the specialist in normal pregnancy, childbirth, and afterbirth care. These are the models that actually make the difference for our communities. In fact, all communities, but particularly our communities, because we have the worst outcomes. We also need then to protect ourselves against being exploited in terms of the research, the medicines, and there's a medicine review going on now in terms of whether pregnant women need to be included in research of medicines. And as I say, we have the all-party parliamentary group. We engage with our members of parliament so that we can keep choice on the agenda rather than people being coerced. And so the future for us as midwives, we're banking on this model to help us to go through. And we're liaising right across the diaspora, gathering the voices of midwives from our communities, of mothers and women who think they would like to become midwives, as well as the families that support them. So thank you very much for the space to begin the work across the diaspora.